Hello my dear friends who live all around the world. Today we are going to discuss about one of the important pharmacology lesson. Diuretics. It is very important and common question in your question paper. And also very important to have proper knowledge on this our day-to-day life. Before going to the video, please subscribe the medical student channel and click the bell icon to get more and more videos related to your studies. And don't forget to share the video and make a comment on this to encourage us. Let's move to the lesson. Diuretics. Excretion of water and electrolytes. Background. Primary effect of diuretics is to increase solute excretion, mainly as NaCl. Causes increase in urine volume due to increased osmotic pressure in lumen of renal tubule. Causes concomitant decrease in extracellular volume, blood volume. Certain disease states may cause blood volume to increase outside of narrowly defined limits. Hypertension, congestive heart failure, liver cirrhosis, nephrotic syndrome, renal failure. Dietary Na restriction often not enough to maintain ECF and prevent edema. Diuretics needed. Review of kidney structure. The kidneys are two bean-shaped organs found in vertebrates. They are located on the left and right in the retroperitoneal space, and in adult humans are about 11 cm, 4.3 in length. They receive blood from the paired renal arteries. Blood exits into the paired renal veins. Each kidney is attached to a ureter, a tube that carries excreted urine to the bladder. The nephron is the structural and functional unit of the kidney. Each human adult kidney contains around 1 million nephrons, while a mouse kidney contains only about 12,500 nephrons. The kidney participates in the control of the volume of various body fluid compartments, fluid osmolality, acid-base balance, various electrolyte concentrations, and removal of toxins. Types of diuretics and therapeutic uses. 1. Carbonic anhydrase inhibitors, work in proximal tubule. Cystinuria, increase alkalinity of tubular urine. Glaucoma, decrease ocular pressure. Acute mountain sickness. Metabolic alkalosis. 2. Osmotic diuretics, proximal tubule, loop of Henle. Acute or incipient renal failure. Reduce preoperative intraocular or intracranial pressure. 3. Loop diuretics, ascending limb of loop. Hypertension, in patients with impaired renal function. Congestive heart failure, moderate to severe. Acute pulmonary edema. Chronic or acute renal failure. Nephrotic syndrome. Hyperkalemia. Chemical intoxication, to increase urine flow. 4. Thiazide diuretics, distal convoluted tubule. Hypertension. Congestive heart failure, mild. Renal calculi. Nephrogenic diabetes insipidus. Chronic renal failure, as an adjunct to loop diuretic. Osteoporosis. 5. Potassium-sparing diuretics, collecting tubule. Chronic liver failure. Congestive heart failure, when hypokalemia is a problem. 6. Osmotic agents, proximal tubule, descending loop of Henle, collecting duct. Reduce pre-surgical or post-trauma intracranial pressure. Prompt removal of renal toxins. One of the few diuretics that do not remove large amounts of Na+. Can cause hypernatremia. Nephron sites of action of diuretics. Natriuretic diuretics are among the most commonly used drugs. They act by diminishing sodium reabsorption at different sites in the nephron, thereby increasing urinary sodium and water losses. A second class of diuretics, sometimes termed aquaretics, instead inhibit water reabsorption by blocking vasopressin receptors along the collecting duct. The ability to induce negative fluid balance has made diuretics useful in the treatment of a variety of conditions, particularly edematous states and hypertension. Background to mechanisms of action of diuretics. Previously told that reabsorption, secretion occurred along renal tubule, but not how this was accomplished. Movement from tubular fluid through renal epithelial cells and into peritubular capillaries accomplished by three transport mechanisms after cell interior is polarized by Na+/K and pump channels. Formed by membrane proteins. Allows only sodium to pass through. Co-transport. Carrier-mediated. Simultaneously transports both Na and other solute, Cl, glucose, etc., from tubular lumen into renal epithelial cell. Counter-transport. Carrier-mediated. Transports Na in, another solute, H+, out of renal epithelial cell. Water moves transcellularly in permeable segments or via tight junctions between renal epithelial cells. Electrolyte transport mechanisms. Important ions cannot pass through membranes by passive diffusion. If they could, maintaining specific concentrations of ions would be impossible. Osmotic pressure is directly proportional to the number of solute atoms or molecules. Ions exert more pressure per unit mass than do non-electrolytes. Electrolyte ions require facilitated diffusion and active transport to cross the semi-permeable membranes. Facilitated diffusion occurs through protein-based channels, which allow passage of the solute along a concentration gradient. In active transport, energy from ATP changes the shape of membrane proteins that move ions against a concentration gradient. Mechanisms of action. Carbonic anhydrase inhibitors. CAIs work on co-transport of Na+, HCO3 and Cl that is coupled to H and counter-transport. Acts to block carbonic anhydrase, Ca. Ca converts HCO3 plus Hn to H2O plus CO2 in tubular lumen. CO2 diffuses into cell, water follows Na+, Ca converts CO2 plus H2O into HCO3 plus H+. Hn now available again for counter-transport with Na+, etc. Na and NHCO3 now transported into peritubular capillary. Ca can catalyze reaction in either direction depending on relative concentration of substrates. Site of action of CAIs. Mechanisms of action, loop diuretics. No transport systems in descending loop of Henle. Ascending loop contains Na+, K+, 2Cl cotransporter from lumen to ascending limb cells. Loop diuretic blocks cotransporter Na+, K+, and Cl remain in lumen, excreted along with water. Mechanisms of action, thiazide diuretics in the distal convoluted tubule. Less reabsorption of water and electrolytes in the distal convoluted tubule than proximal tubule or loop. Na+, Cl cotransporter there is blocked by thiazides. Mechanisms of action, collecting tubule and potassium-sparing diuretics. Two cell types in collecting tubule. Principal cells, transport Na, K, water. Intercalated cells, secretion of H and NHCO3. Blocking Na and movement in also prevents K and movement out. Summary of sites of renal reabsorption of filtrate. Types and names of diuretics. General background of diuretics. Pattern of excretion of electrolytes, how much of which type, depends on class of diuretic agent. Maximal response is limited by site of action. Effect of two or more diuretics from different classes is additive or synergistic if their sites or mechanisms of action are different. Osmotic diuretics. No interaction with transport systems. All activity depends on osmotic pressure exerted in lumen. Blocks water reabsorption in proximal tubule, descending loop, collecting duct. Results in large water loss. Smaller electrolyte loss can result in hypernatremia. Carbonic anhydrase inhibitors. Block carbonic anhydrase catalyzation of CO2/carbonic acid/carbonate equilibrium. Useful for treating glaucoma and metabolic alkalosis but can cause hyperchloremic metabolic acidosis from HCO3 depletion. Loop diuretics. Generally cause greater diuresis than thiazides, used when they are insufficient. Can enhance Ca2+ and Mg2+ excretion. Enter tubular lumen via proximal tubular secretion, unusual secretion segment, because body treats them as a toxic drug. Drugs that block this secretion, e.g. probenecid, reduces efficacy. Thiazide diuretics. Developed to preferentially increase Cl excretion over HCO3 excretion, as from CAIs. Magnitude of effect is lower because work on distal convoluted tubule only receives 15% of filtrate. Cause decreased Ca excretion, hypercalcemia, reduce osteoporosis. Potassium sparing diuretics. Have most downstream site of action, collecting tubule. Reduce K loss by inhibiting Na/K exchange. Not a strong diuretic because action is furthest downstream. Often used in combination with thiazide diuretics to restrict K loss. That was the brief description about diuretics. Thank you so much for watching the video and wait for another valuable video very soon. If you have any suggestions, comment below. Please subscribe the Medical Student channel and click the bell icon to get more and more videos related to your studies. And don't forget to share the video and make a comment on this to encourage us. Have a great day.